That night, my new assistant asked a question, and that question landed like a scalpel in my heart. It was almost closing, the kind of hour when a clinic stops feeling like a workplace and starts feeling like a sealed box. The compressor settles into its low mechanical breathing, the fluorescent lights lose their warmth, and every small sound in the hallway becomes too clear. My assistant had been with me only a few days, brilliant on paper, disciplined in practice, and hungry to learn private chamber work from someone whose hands had already seen every predictable complication dentistry can throw. He was wiping the chair armrests, flushing the suction line twice, and lining up instruments with a precision that looked like faith. Then he noticed what everyone eventually notices. I took an empty specimen cup, placed it inside the back cabinet, locked the cabinet, checked the lock once more, and only then switched off the operatory light. The cabinet held nothing valuable, no controlled drugs, no precious materials, nothing that would make sense to protect like that. He hesitated, then asked why a senior surgeon would treat an empty cabinet like a threat. His tone was respectful, but curiosity has a sharp edge, and it found something tender in me. For a moment, I considered giving him the safe answer, the one that ends the conversation quickly. I could have told him it was habit, discipline, infection control, professional routine, all true and all incomplete. Because the real reason had nothing to do with germs. The real reason was that once, long ago, I locked a tooth away for proof, and it taught me that proof can turn into permission. Before I told him the story, I gave him the background he deserved, the context that would stop him from dismissing what came next as a young doctor's mistake. I told him I had not stumbled into dentistry. I had earned my place through the usual gauntlet the top surgeons go through. Strong academics, competitive clinical training, high-volume rotations, exposure to oral surgery cases where speed and precision are not luxuries but necessities. I had managed complicated extractions, broken roots, deep infections, severe anxiety patients, medical emergencies in the chair, all the scenarios that train you to keep your hands steady even when the room is not. I had built a practice on documentation, discipline, and results, the kind that brings referrals without advertising. Then I told him something I rarely admit out loud. None of that mattered the night the tooth returned. The case happened when I was in my 30s, long before grey hair and locked cabinets, when I ran a private practice in an isolated part of America that felt intentionally forgotten. One main road through town, pine trees packed so tight they swallowed headlights, and a silence at night that felt employed, like it was paid to keep secrets. My clinic sat slightly away from the center, an old medical building I kept spotless out of pride. The sign outside buzzed on cold nights. There were no streetlights in the lot, only the glow from my front windows and the pale wash of the moon when clouds allowed it. It began on a Wednesday evening, late enough that the last appointment was done. The staff had left and the building had shifted into its after-hours personality. I had already turned off half the lights. The air inside had that faint scent of disinfectant and warmed plastic that every dental clinic carries. I was thinking about dinner and the comfort of routine. Then the bell over the front door rang once, not frantic, not pleading, just a single thin note that sounded deliberate in the quiet. A man walked in who looked like he had rehearsed being normal. Middle-aged, clean jacket, no mud on his boots, which was odd for that season. He held his jaw with a careful grip, as if moving wrong could spill the pain into the room. He gave his name and date of birth, and I recognized him the way you recognize a file you have not opened in years. He was not a frequent patient, but he was in my system, and that alone should have anchored the moment. It did not. He reported severe toothache in the lower left side, deep and pulsing. Worse at night, the kind that makes grown men quiet. His voice stayed calm, but his eyes were not calm. They moved around the room too often, not in the anxious, patient way, but in the listening way, like he expected something to answer before he did. When I guided him to the operatory, he paused in the doorway and looked at the dental chair like it had memory. I began the assessment the way any proper clinician does. I asked about triggers, duration, prior procedures. He indicated the tooth that hurt was the lower left first molar. Then he indicated that tooth had been extracted years earlier by me. My mind did what minds do when faced with something absurd. It reached for paperwork. Paperwork is comfort. Paperwork is structure. Paperwork is a fence around chaos. I opened his folder right there. The extraction note was clear. Uncomplicated removal of the lower left first molar, performed by me. Anesthesia noted. Socket irrigated. Post-op instructions. Follow-up visit documented. Healing confirmed. I had even drawn a quick sketch of the gap, the space where the tooth used to be. My own handwriting declared the case closed. I explained that the tooth no longer existed and that pain can be referred from adjacent teeth, from the jaw joint, from a crack in a neighboring tooth, from sinus pressure. I said the sensible things. He did not argue. He only indicated I should look before deciding. So I leaned in with the light, expecting a healed ridge, maybe irritation on the gum. Instead, I saw a tooth, a complete molar, seated exactly where the extracted one had been. Same position, same shape, same wear pattern. The grooves had the same faint staining I remembered. One cusp had a tiny flattened edge, like it had been ground down by years of chewing. It did not look newly erupted. It did not look like a leftover fragment. It looked like it had never left. The room felt smaller while I stared. The overhead light seemed harsher. The quiet changed from normal quiet to attentive quiet, as if the building held its breath. I checked again, slower, probing, percussion. Gentle palpation. The tooth responded like a tooth. He reacted with real pain. No theatrics, no performance. The pain was honest. I took an X-ray because the film is supposed to be reality's receipt. The tooth appeared on the image exactly where it should, roots and all. But the anatomy looked too clean, too perfectly arranged, like a diagram pretending to be a patient. The surrounding bone density was oddly uniform. There were none of the normal signs that should have matched his level of pain. It looked like someone had copied an old image and pasted it into the present. I asked how long the tooth had been back. He implied it returned after he apologized to it. He explained indirectly, like a man ashamed to say something he knew would be judged. He implied he had blamed the tooth for years, blamed it for pain, missed work, money, embarrassment, the way people blame a single object for everything that went wrong in their body. During a storm, he woke up with his jaw aching and apologized out loud into the dark, sincerely, like he was apologizing to a person. The next morning, he checked the mirror, and the tooth was back. Then he implied something worse. He implied it came back wrong. He wanted it removed immediately. No debate, no options, no conversation about root canal or restoration. He wanted it out with the urgency of someone trying to remove a parasite rather than treat a tooth. At that point, my assistant, the younger man sitting across from me in the present, shifted in his chair. I could see it in his posture. It was the moment he expected me to confess a mistake, a misread chart, a patient with a similar name. I told him I had already checked those possibilities that night. I had checked them the way an experienced surgeon checks a bleeding artery. Quickly, thoroughly, without hope that denial will help. The identity matched. The chart matched. The tooth in the mouth matched the tooth that should not exist. So I did what a dentist does. I treated the pain. I administered local anesthesia. I prepared for extraction. I told myself that if I removed the tooth and held it in my hand, reality would have to behave again. That proof would restore order. The tooth resisted at first, then released too easily, almost like it had been waiting for permission. It came free cleanly. No fracture, no complication, too neat for something impossible. I placed it in a specimen cup immediately. Not for lab work, not for insurance, but for proof, a physical anchor, something I could touch. The patient left with instructions and gauze. He did not look relieved. He looked lighter, like he had handed me a burden and walked away before I could refuse it. After he left, I locked the specimen cup in the back cabinet. It is important to understand why. In those days, I was not a superstitious man. I did not believe in curses. I believed in bacteria and physics and anatomy. But that night, something in my instincts had spoken, and I listened. The instinct told me that if a tooth could return to a mouth after being extracted years earlier, it could also refuse to remain anywhere I placed it. The lock was not about theft. It was about containment. That night, sleep came in pieces. Not nightmares, not cinematic terror. Something more unsettling. I kept waking with the sensation that fine grit was caught between my own teeth, a persistent awareness that something small and wrong was inside my mouth. I checked. Nothing. Rinsed. Nothing. The sensation returned the moment the room went dark, like the darkness itself was part of the mechanism. Before sunrise, I drove to the clinic, earlier than I had ever arrived, driven by the need to confirm that reality had not moved again while I was gone. The cabinet lock was intact. No scratches, no signs of tampering. It opened normally. The specimen cup was inside, empty, no tooth, no moisture, no residue, just air and a faint metallic smell. At the bottom was a folded slip of paper. The paper was written in my handwriting. This is the part that still makes my stomach tighten even now. Handwriting is intimate. It is not just letters, it is muscle memory, it is rhythm, the loops and slants that belong to a single body. The note carried those details perfectly. The message implied I should stop taking what I was not owed. No signature, no explanation, just correction. I stood there with the empty cup in one hand and that note in the other, and it felt like I had been addressed by something that did not care about my credentials, my license, my training. Something that treated my clinical authority like a child's badge. Empty. I did not call the police because there was nothing I could report that would not make me sound like a man losing his mind. I did not call a colleague because professional pride is a powerful gag. I did what many people do when the world shows its teeth. I tried to continue. That afternoon, the patient returned. He implied the tooth was back again. He sat, opened his mouth, and there it was. Same molar, same wear, same stains, same impossible certainty. And the extraction site from yesterday looked wrong. Too clean, too calm, as if time had been edited. I attempted to keep the encounter in the medical world. I retook images, I rechecked identification, I asked if he had kept the extracted tooth. He implied he had not. He implied he could not keep it even if he wanted to. Then the patient said something indirectly that changed the shape of the entire case. He implied that the apology had been imperfect. He implied the tooth knew the difference between apologizing because one wants comfort and apologizing because one accepts guilt. He implied it returned because it had been invited, but it stayed because the invitation had created terms. Terms. That word should never belong in dentistry. Teeth do not negotiate. Teeth decay, fracture, heal, fail. They do not make demands. But that was the sensation in the room. A negotiation I did not understand. I refused to extract it again. I told him I would refer him for medical evaluation, advanced imaging, possibly neurology, anything that could place the problem into a system with rules. He listened politely, then implied it would not matter. He implied the tooth was not a medical problem anymore. It was a claim. He left calmly, which was almost worse than panic. Calm meant he knew something I did not. Over the next week, the case did not disappear. It spread. His chart began to change in subtle ways. At first, I thought it was my eyes. The ink on the old extraction note looked faint in places. The sketch of the missing tooth blurred as if rubbed with an eraser. Dates seemed slightly smudged, not wet, but softened. I told myself it was paper aging. I told myself the office humidity was wrong. Then a stranger twist arrived, the kind that feels petty in the moment and devastating afterward. My receptionist told me a man had called asking about an appointment that did not exist on the schedule. The name was the same patient. The time was odd, a slot after closing. When I checked the book, there was no appointment. Later that night, the phone rang once after midnight. When I picked up, there was nothing on the line, but there was a quiet sound like breathing, not through a mouth, but through a room. The next morning, a voicemail appeared. The voice on the message sounded like mine. Not exactly, but close enough to make my skin prickle. The voice explained a treatment plan for a tooth that should not exist, and it did it with the calm tone I use when I want to reassure anxious patients. The message ended abruptly, mid-sentence, like someone had stopped recording because they noticed they were being listened to. I started keeping a private log then, not because I wanted to be dramatic, but because I no longer trusted the official chart to remain stable. I wrote the basics twice, once in the patient record and once in a separate notebook in my own hand, my own pen, because some primitive part of me believed redundancy was protection. Then came the night of the second cabinet. I had locked the specimen cabinet out of habit at closing, even though it was empty now. As I turned off the operatory light, the overhead bulb in the second room flickered once, a single flicker, like a blink. I walked back and checked the cabinet lock again. It was secure. I turned to leave and heard a small click behind me, the kind of sound a latch makes when it settles. The cabinet door was still closed. But the click did not belong to the door. It belonged to the specimen cups inside. The cups were stacked, plastic on plastic. They do not click unless something moves them. I did not open the cabinet that night. I left one operatory light on and sat at my desk until sunrise, pretending paperwork mattered, pretending the building was not paying attention. Nothing attacked me. Nothing appeared in the corner. The terror was not about seeing a monster. It was about realizing the rules had changed and I had not been informed. When morning came, I opened the cabinet in full daylight. A specimen cup sat at the front as if someone had placed it there for me. Inside was a tooth, not the patient's tooth, a tooth with a small strip of tape wrapped around the root, the way labs label samples. The label had my name. I checked my mouth immediately, the way every clinician does when the professional becomes personal. The tooth was still in my mouth. X-ray confirmed it. Yet the tooth sat in the cup on my desk, identical in shape, identical in wear, like a duplicate produced for a reason I could not guess. That was the moment the note made sense. The message about taking what I was not owed had not been about extraction or treatment. It was about ownership, about the arrogance of assuming that if I touched something with gloved hands, if I wrote it in a chart, if I sealed it in a cup, it belonged to my system now. Whatever this was, it was telling me my system was not the only system in the room. I tried to end it the way professionals end problems. I contacted a specialist colleague in a nearby city and requested a consult without using dramatic language. I sent copies of imaging. I asked for a second set of eyes. When the response came back, it was short and clinically polite, the kind of message that quietly implies a colleague is overworked or unstable. The consultant indicated the images looked manipulated or copied, and he suggested retaking them with a different machine. He also suggested gently that stress can cause perception errors. I retook the images. They still looked wrong, and then the patient vanished. Not in a dramatic way. He simply stopped existing in the practical sense. The phone number no longer worked. The address on file came back invalid when I tried to mail a follow-up notice. No record requests came, no family called, no one in town mentioned him. It was as if he had only ever been present inside the boundaries of that toothache claim, and when the claim moved, he was no longer required. I moved my practice within 2 months. On paper, it was a business decision. Better location, better foot traffic, better access for patients. In my own mind, it was retreat. I did not tell anyone the truth. Not then, not for years. I packed my instruments, my charts, my equipment, and I left that building behind like a bad dream. But the habit followed me. I started locking specimen cups even when they were empty. I started double writing critical notes, once in the chart and once privately. I stopped scheduling late appointments whenever possible. I kept one operatory light on after closing. These were not rituals for comfort. They were boundaries, the smallest boundaries I could enforce in a world that had proven it could cross bigger ones. When I finished telling the story, my new assistant in the present had gone quiet. Not skeptical quiet, but processing quiet. The kind of quiet that appears when a young doctor realizes the profession has corridors nobody tours in dental school. He asked indirectly whether I believed the tooth was haunted. I told him I did not know what to call it. Haunted implies drama. This felt more like accounting. Like something keeping track, not with anger but with rules. Then I told him the twist that still wakes me up on certain nights. I never found the duplicate tooth again. It did not show up in a cabinet. It did not show up in the trash. It did not show up on my desk. It simply stopped appearing. But the sensation of grit between my own teeth, that awareness that something small and wrong was present, returned every time I acted careless with ownership. Every time I dismissed a patient's complaint too quickly. Every time I treated a case like a problem to conquer rather than a person to serve. It would return for a few hours, then fade, as if something was reminding me who was watching. And that is why, tonight, an empty cabinet still gets locked. Not because I expect a tooth to reappear. Because once, long ago, a tooth proved it could. And because the most frightening part of that case was not the impossibility of the tooth coming back. The most frightening part was the feeling that something else had read my confidence, understood it perfectly, and decided to correct it with my own handwriting.